Welcome to the Data Best Practices webinar. Your presenters today will be Joe Bradley, that's me, from WNC Health Network. I am the Health Data and Improvement Specialist here, and Emily Kajawa from Kajawa Consulting, who is a qualitative data consultant. I don't know if you want to say hi, Emily.
Sure. Hi, everybody. I'm really happy to be on the webinar with you all today.
Thanks, Emily. Just a little bit of context for today. The WNC Health Network has been helping hospitals and public health agencies over the past year to identify and dig into performance measures for their hospital implementation strategies and community health improvement plans. So with this includes some data collection and sharing for performance measures that we are trying to identify and create and collect data on. This would also include the reporting of the performance measures, numbers and story, either in SCORECARD or in some other method. The WNC Health Network is also working on human-centered design projects with hospitals and public health agencies. There will be a human-centered design toolkit that's going to be available soon. I hear from Maren that that's going to be in mid-August. And with that, we are encouraging them to make observations and do interviews, and then report and share results on that as well. And don't forget, it is not too early to start thinking about the local data collection for the CHA 2018. So with that, there might be surveys and focus groups done at the level that you will need to report and share results on as well. So just kind of with all this in mind, we decided it was a really good idea to get some data best practices out there while you're thinking about performance measures, human-centered design projects, and local data collection coming up. Today's topics are going to include a broad topic, section 1, data collection, which will be an overview of ethics, obtaining informed consent, considerations for numbers, which we're calling the quantitative data here, considerations for story, which is the qualitative data, and who might you consider talking to before you go out and collect data. The second section is really going to be about data security and storage, so a little bit of an overview on protected health information, limited data sets and sensitive data, some HIPAA compliance overview for hospitals and public health agencies, and data storage and sharing best practices as well. The third section is going to focus on data reporting, some general best practices for reporting numbers and story, and then best practices for reporting data via the scorecard as well. And then at the very end, we'll have some FAQ. So if you feel like you have some urgent questions, go ahead and enter those in the chat box, and we'll try and get to them at the end. Or when I unmute everybody at the end, you can ask your question. This section is going to be about data collection. So the first thing you want to consider, much like RBA, is who is your customer for the data. Once you identify the customer for the data, then you can begin to consider the ethical, compliance or regulatory or practice improvement considerations for that data. So what is your data going to be used for? For example, is it going to be for you to make improvements about your work? Is it a QI or program improvement project? A report for funders, something you might want to publish? All of the answers to these questions are going to lead you down a different path of what kind of data you need to collect and what you need to do before you start collecting that data. We're going to get to ethical considerations in just a little bit, but just to know that you need to think about this before you start that data collection, just like you think about it before you create performance measures and get that information. I did miss one point that I wanted to make earlier, which was Emily and I are both going to be using data and information interchangeably throughout this webinar, so I wanted to make sure that everybody knew whether we say data or information, we mean the same thing when we're saying it, just to keep us all on the same page. Overview of the ethical considerations. So a lot of the information that we included in this first section on data collection comes from academic resources and not community-based research. We realize that most of you are doing community-based research, and so really you want to think about what is good enough data and for you and your data needs. These are kind of the overarching ethical considerations when you are doing data collection. So when you're doing your data collection, what does the data collector not know or is not able to match the response with the participant? Is that important for the data that you're collecting? Is the information given by the respondents going to be released to anybody? Are the results going to be summarized across respondents? It's really going to vary based on your data collection needs and your customer, but just something to think about while you're beginning your process of data collection. Are you going to need informed consent? Will the participants be fully informed about the risks and benefits of the data collection that you're doing? Did you make sure that the procedures and instruments are culturally and language appropriate? Participants should not be harmed, or harm should be kept to a minimum. How are you protecting the participants? No one should be forced to participate. Are you forcing your participants to answer every question? Are you providing incentives or compensation for participating that are creating undue influence? Just things to think about. Of course, you'll want to check with your organization's IRB or ethics review body to ensure that the project protects human subjects. If you're at all concerned that it might involve human subjects to an extent where you feel like you should talk to somebody, go ahead and talk to somebody. I always recommend being a little bit on the safe side when you're thinking about data collection. Informed consent general guidelines. I recommend that you give the potential participants some kind of information about the data collection project that you're doing, whether that's verbal, some kind of description, a cover letter, a line at the top of your SurveyMonkey, just to make sure that they know what they're getting into. If you have participants sign some kind of consent, electronic or paper document, you want to make sure that if there are children present, that the parents are signing the form. If you have cover letters and consent forms and your participant base has multiple languages, you want to make sure that you have consent forms in those languages. So just things to keep in mind for your data collection. Some exceptions to the rule. In some cases, just returning the questionnaire or answering the phone, like our regional phone survey, implies consent, and you won't need a consent form. Some practice-related data collection, the clients might have already given consent to participate in the data collection when they signed up for the service. This could come into play when they sign up for a program through the health department or hospital. For observational data, you might not need consent if it takes place in a public setting. There are a couple exceptions. One is if children are being observed. Typically, you won't need it if you're not observing children. The observations are recorded in a manner in which the subjects cannot be identified. The observations do not reasonably place the subject at risk. And I believe those are the three main ones that you won't need consent for. Most types of secondary data and using data already collected do not require informed consent. And special and vulnerable populations, including those listed here, may have some kind of extra consent that you'll need to provide. Some information that you might want to include in a informed consent, either verbal description or cover letter. Things you might also consider if you're doing an electronic survey, just kind of putting up in a big information box at the top of the survey. The purpose of the data collection and when or where it's going to take place, the information about how data is being collected, information about possible benefits of the project or service that this data is going to give, information about possible risks to participants, a statement that participation is voluntary and that they can withdraw or not answer questions if they don't feel like it, information about any incentives that will be provided, information about where the project coordinator can be contacted for more information, and information on how the results are going to be used if and when the results are available to the public, participants or the public. Some considerations for numbers, quantitative data collection, which could be surveys or questionnaires. Surveys and questionnaires are tools that can provide you with numbers, data. This can be through, so through open-ended questions, you can also get story data as well. Two areas you want to consider when you're looking at surveys and questionnaires are informed consent and the social and medical science credibility. Now, these two things and the considerations that you make about them is really going to be about what kind of data you need and what's the best data. So I did include a chart earlier, and in the source I have a chart that kind of breaks out a crosswalk of the ethical tenets for informed consent and social and medical science credibility. I'm actually not going to go over that, and I will attach that in the resources that goes along with this. But those include a crosswalk for both of those for autonomy, beneficence, non-malfeasance, and justice. And it does informed consent and social and medical science credibility for all of those for surveys and questionnaires. Emily?
Okay, great. Thanks, Joe. So I'll talk a little bit now about some considerations for qualitative data collection. So as you all probably know, qualitative data is really useful to help you tell the story behind the numbers or the quantitative data that Joe was just discussing, and it can help provide rich context and yield important insights into the how and the why behind your quantitative data. The most common types of qualitative data collection methods you will probably be using for either the human-centered design projects or the community data collection for the CHA will probably include observations, one-on-one interviews, and focus groups. In general, the same basic ethical principles apply to these methods as apply to the quantitative data methods that Joe discussed earlier. These considerations include informed consent, confidentiality, and minimizing risk for participants. In addition, there are some other considerations for qualitative data collection. For observational data collection, which entails, possibly, like Joe said, going out into the community, into either public settings and collecting observational field notes. It could also include going into a hospital and either observing staff or patient behaviors. It could include going into a variety of different community-based organizations or schools or community rec centers and just collecting kind of field notes to understand kind of the current state or status of either project implementation or observed gaps, that kind of thing. For this type of observational data collection, you may or may not need written informed consent, and Joe talked a little bit about already in truly public settings, you likely will not need written informed consent. There's no kind of standard definition for what a public setting is, but generally just think about if you're going to be in a, like a public park or on a street corner, just observing general public behavior, you likely will not need to obtain informed consent. There are several exceptions, as Joe mentioned. If you are observing children, if your target population is primarily children, I would say you may need to consider whether or not you'll need to obtain consent. So for example, if you are making observations on, the sidewalk across from a school, chances are there will be a lot of children coming and going throughout the day. That would be a situation where you would probably want to refer to your organization's own guidelines around informed consent for children and minors, and also talk with the school and find out what guidelines or rules they have around collecting data with their children in that target population. Another consideration is just ensuring that the manner in which you record the data will ensure that the subjects cannot be identified. So a little bit later in the webinar, Joe's going to talk about a list of specific types of data that are considered identifiers, and you'll want to make sure that any field notes that you take, any other sorts of data you collect through observations do not include those identifying those identifiers. And finally, you'll want to ensure, again, as Joe mentioned, that any observations you record would not reasonably place anyone that you're observing at risk if they were to become known outside of the data collection process. So that can include any legal or financial or employment data. So beyond that, the first step that you would want to do to determine if you need to obtain informed consent with your observations is to find out what your organization's own rules or guidance are for conducting qualitative data collection. This will probably involve talking with your organization's either HIPAA compliance officer, quality improvement department, ethics review body, or a similar entity, and we'll talk more about this on the next slide. So after you've found out what your organization's own guidelines are, the next step is to notify the, quote, right people that you are collecting data. And these right people will definitely include gatekeepers of any institution or organization within which you want to gather observational data. So that would include, obviously, you know, if you're hoping to collect data in a hospital, within the public health agency, at a community center, YMCA, school, that kind of thing. You'll definitely want to talk with any gatekeepers there. And again, we'll talk about who those specific people might be on the next slide. And they should be able to give you more information about their organization's own rules or guidelines for getting consent from observed individuals. And you should plan to come to those conversations with those gatekeepers prepared to discuss the details of how you want to collect data. So the process, the methods you would use, the safeguards you'll have in place to ensure confidentiality, how you plan to store the data in a secure way, and how the findings will be shared. So as Joe mentioned, you may be collecting data for a variety of purposes, whether it's internal quality improvement, it might be to inform the community health assessment, in which case the data may be shared in public reports or scorecards, that kind of thing. So just be sure you come to those conversations prepared to share those details. If either your organization's own guidance or the guidance from the organization in which you're collecting data do require informed consent, obviously you will need to obtain that consent from anyone from whom you'd like to collect observational data. And there are a variety of kind of tools and templates out there for consent forms. We can talk about that more on the resources slide at the end. If your organization's own guidance and the guidance from the institution or organization in which you want to observe do not require written informed consent, you may still need to make people aware of your data collection and give them the opportunity to opt out of participation. So for example, if you determine that you won't need to get like a signed written consent from everyone, you may still need to provide a data collection information sheet, which could be posted, for example, as a flyer on a bulletin board somewhere, or it could be handed out to individuals who may be visiting a clinic that you're doing observations in. And of course, if any individual chooses to opt out, you must not include any observations or information about them in your field notes or other data that you collect from them. And then just again, a reminder, if you want to observe vulnerable populations, which include children, prisoners, pregnant women, mentally disabled persons, people with economic or educationally disadvantaged backgrounds, you may need to include additional safeguards. And again, just refer to your organization's own guidelines around these. So another important step to ensuring you adhere to appropriate ethical and consent principles is establish data collection procedures that minimize risk and maximize confidentiality. And for the purposes of observational data collection, some of these procedures might include ensuring your field notes and transcripts do not contain personal identifiers, which again, we'll talk about in a little bit. It might include keeping raw and processed data in the storage that is either physically locked or in electronic files that are password protected. It may include sharing data only with those who are part of the data collection team and who have received research ethics training. And if you're supervising a team that collects data, make sure that you are conducting training with all of them. These procedures might also include establishing a clear chain of custody to ensure data is not diverted or lost, and then conducting regular audits of yourself and your team to ensure you're complying with these guidelines. So again, just make sure that you understand what your own organization's rules or guidelines are around maintaining these type of confidentiality and security of data. And Joe will talk more about data security later. As far as focus groups and interviews, if these are methods that you want to use, you'll first need to understand existing rules or guidelines. You're starting to hear a theme here that your organization has, as well as any rules from organizations in which you want to collect the data. So in general, obtaining written informed consent from individuals who participate in interviews or focus groups is much easier than obtaining written consent for those you may only be observing. So if there's any question on whether or not you should obtain written consent for interviews and focus groups, I recommend erring on the side of caution and going ahead and getting written consent. And then obviously when you're actually conducting the interviews and focus groups, ensure that procedures and protocols are in place to minimize risk and maximize confidentiality, similar to what we just discussed. A couple of additional considerations for focus groups and interviews include audio and videotaping. So if you do want to audio or videotape your sessions, participants should be informed before the focus group or interview begins if it will be recorded and what will be done with the recording, such as how it will be recorded and for how long it will be stored, and how the information in the recording will be used. Language describing how the recording will be used should also be included in the consent form. And there are example consent forms available that include that type of language. Confidentiality for focus groups is also unique in the sense that they involve groups of individuals who will hear information that others in the group have to share. As a result, focus groups require additional steps to ensure confidentiality is maintained. So focus group participants should be instructed to not repeat anything that's said during the focus group, and should also be informed of the procedures that will be followed to maintain confidentiality by the researcher. And language about these topics should be included both in the consent form as well as in the focus group moderator script. And there is template language available if that's something that would be useful. We can discuss this with you further.
Thanks, Emily.
So who might you need? Yep. Oh, do you want me to do the next slide too, Joe?
Sure.
Or do you want to do this one? Okay. So who might you need to consider talking to before collecting data? So again, as I mentioned, one of your first steps before you start the data collection process should be to talk with the key staff or gatekeepers, both at your own organization and in the organizations in which you want to collect data. So who these people are is organization dependent, but here's a few possible suggestions to get you started. And obviously you'll just kind of need to follow the trail to get to the right people. So for those of you who are working in hospitals or health systems, you may want to start out talking with, again, your HIPAA compliance officer. If you have an IRB or a human subjects committee, those would be good places to start to understand what guidance you must follow. And then if you're planning to collect data on individuals within the hospital, you may also need to talk with additional staff, such as HR department staff if you want to collect data on staff or employees, or again, back to the IRB or Human Subjects Committee, or compliance or risk management staff if you want to collect data on actual patients. And for those of you in public health agencies, the internal staff you'll need to talk to will probably vary from county to county, but usually a good place to start is the staff person who oversees either quality improvement or HIPAA compliance for your agency. The actual position title for this person may vary, but it could be someone in charge of clinical services, such as a nursing director. It could be health education staff or others. And in addition, you should also plan to talk with staff who work on the specific disease topics or disease states you're planning to collect data on. So for example, infant mortality, disease control, STIs, STDs, etc. And then again, if you want to collect data in another type of organization, such as a community rec center, school, YMCA, you should talk with either the director, the manager, or another gatekeeper ahead of time.
Perfect. Thank you. All right, so this section we are going to go over data security and storage, and I know a lot of hospitals and public health agencies do a ton of protected health information training, so I'm going to try and move through these slides as quickly as possible so that we have some time for questions at the end. Protected Health Information 101. So while the intent of your data collection might not be to collect PHI, we want to make sure that you have the following guidance and it's provided should you encounter any of it in your data collection efforts. So protected health information, remember the privacy rule protects all individually identifiable health information held or transmitted by a covered entity or its business associate in any form or media, whether electronic, paper, or oral. The privacy rule calls this information protected health information. This includes information and data that relates to the individual's past, present, or future physical or mental health or condition, the provision of health care to the individual, or the past, present, or future payment for the provision of health care to the individual, or the individual's identity, or for which there is a reasonable basis to believe it can be used to identify the individual. I really like this infographic, unsecured PHIs everywhere. It shows a person and then all the ways PHI can live in an office environment, just out there for everyone to see. I just like to show that as a picture of it. This is the list of the 18 direct identifiers. So these are examples of the sensitive identifiable information and elements that Emily was referring to earlier. This includes names, postal address information other than town or city or state, and zip code, telephone numbers, fax numbers, electronic mail addresses, social security numbers, medical record numbers, health plan beneficiary numbers, account numbers, split onto 2 slides because there's so many, certificate and license numbers, vehicle identifiers, device identifiers, web universal resource locators, internet protocol, biometric identifiers, full face images, and these 2 are specific, I think, to Duke, all elements and of dates related to the individual, including birth date, admission date, discharge date, and date of death, and any other characters that can be used to uniquely identify the individual. So typically it's 16 identifiers. For Duke, it is 18 direct identifiers. A limited data set refers to PHI that excludes these 18 categories of identifiers, and it may be used or disclosed for the purposes of research, public health, healthcare operations, or research without obtaining either an individual's authorization or a waiver or an alteration of authorizations for its use or disclosure. So if you share a limited data set outside of your organization, you need to refer to the data sharing practices outlined in the data use agreement. The data use agreement is the means by which covered entities obtain satisfactory assurances that the recipient of the limited data will use or disclose the PHI in a data set only for specific purposes. What I find interesting is even if the person requesting a limited data set from a covered entity is an employee or otherwise a member of the covered entity's workforce, a written data use agreement must be in place. So just to know, if you're asking for a limited data set, you do need a data use agreement with the covered entity, whether that be the hospital or the health department. De-identified data is the process by which you take all of the 18 identifiers out of the information. Sensitive data is a tricky one. It's defined as information that is protected against unwarranted disclosure. Access to sensitive information should be safeguarded. Protection of sensitive data may be required for legal or ethical reasons, for issues pertaining to personal privacy, or for proprietary considerations. You want to use your best judgment when sharing sensitive data. If the data is considered to be sensitive, then you'll want to carefully consider how and with who you're going to share the data with. How do you know if you need to comply? Remember, covered entities are defined in the HIPAA rules as health plans, healthcare clearinghouses, healthcare providers who electronically transmit any health information in connection with transactions for which HHS has adopted standards. This is true for public health agencies and hospitals. Who else might need to comply to these standards? A business associate is a person that performs certain functions or actions that involve the use or disclosure of PHI. This could be consultants, contractors, subcontractors, health information organizations, data storage facilities, even the copier or shredding companies have to have a BA if they are coming into contact with PHI. The business associate agreement is the contract between the covered entity and the person getting the PHI. If you share any PHI outside your organization, you need to refer to the data sharing practices outlined in your organization's BAA. This is just a reminder, HIPAA violations are very expensive and can range from $100,000 to $50,000 per violation, with a maximum penalty of $1.5 million, which is why it's so important to focus on safeguarding this information. This is just a list of primary causes of data breaches. I think they are ranked in order here. So a lost or stolen computing device, employee mistakes or unintentional actions, third-party snafus, criminal attack, which may be bumped up the list a little bit here, technical systems glitch, malicious insider, or intentional non-malicious employee action. So a data breach would be when PHI is accidentally disclosed or lost or stolen inside your organization, inside or outside. Now, the procedure for reporting a security breach, you of course want to go with your organization's guidelines. They're usually reported to a compliance or risk management office. If that office does not exist in your organization, make sure you report a breach to anyone in a leadership role and document who it was reported to. And then be sure to check with your organization and HIPAA compliance for more specific information. A data breach could even be someone accidentally emailing you some protected health information, just sharing for, hey, take a look at this data, I need help analyzing it. You'd want to report that data breach back to the person if you receive that email, and you'd want to let them know how you destroyed it as well. These are some typical data security measures most of your organizations will have in place for you. And then I've added some other ways you can also increase security if you're worried about your data. Typically, laptops will be password protected. Outgoing email is going to be automatically encrypted. Network drives are going to be encrypted and backed up. Other ways you can increase this might be to create passwords to protect devices, encrypt your documents, create security permissions for folders, encrypt cloud-based sharing software, making sure you use HIPAA-compliant cloud-based sharing software and also HIPAA-compliant cloud-based survey software if you're going to be collecting any PHI. It's a good idea to get the HIPAA-compliant cloud-based sharing software, even if you think you might just, you won't encounter it, but there might be some sensitive data in there. You want to encrypt flash drives, ensure devices, including personal computers, are kept up to date on operating systems and virus protection. The emphasis on these last three bullets is really going to be with the ransomware attacks that we've had lately. So maintain routine backups of the data that can be recovered as necessary, and avoid phishing emails. So if it looks fishy, think before you click. Disposing of that PHI, this is if you accidentally get that email. Remember, in my example, you'll often need to complete a certificate of destruction for both electronic email and paper PHI. You'll want to keep that certificate of destruction on file according to your local protocol, your organization. And you'll want to check with your organization's HIPAA compliance for more specific information about disposing PHI. Some say you have to keep this electronic or certificate of destruction indefinitely, but usually it's about 6 years. You can always keep this uploaded in an electronic way and not in your file folder. So just to recap on data sharing best practices, make sure you know what type of data you're sharing. Is it PHI? Is it de-identified? Is it sensitive? Is it just aggregate data? And the policies, you're going to hear this over and over, that your organization has in place for sharing it. So PHI, hospitals and public health agencies, you have policies in place about how to share PHI within your organization. If sharing PHI outside your organization, you want to refer to the data sharing practices outlined in your BAA. And if you're going to share it, you're going to need a BAA. A limited data set, if you're sharing a limited data set inside or outside your organization, refer to the data sharing practices outlined in your DUA. And sensitive data, use your best judgment when sharing this. the data is considered to be sensitive, then you'll want to carefully consider how and with who you're going to share the data. Aggregate data, this can be shared pretty much via email or even SCORECARD pretty easily. Be aware that sometimes small numbers, even if they're aggregated, could be considered sensitive data. So just be careful about the data that you're sharing. Data reporting best practices. So this is by no means a complete list of data best practices, but Emily and I just tried to put some data best practices together that have risen to the surface over the past year, and keeping in mind with our different projects, performance measures, human-centered design, and local CHA data collection coming up in 2018. I know that there are also a couple data experts on the webinar today, so I'd love it if you all think of any data best practices that you want to share and are not mentioned, to go ahead and share them in the Q&A or email me after the webinar, and we can get those put in the document FAQs. So for sources, when you're either reporting this verbally or in a document, you want to make sure that you report the source of data for all your numbers or story that you're collecting. Same for data definitions. If you're going to be giving a presentation on data, you want to understand the basic data definitions for any data that you're presenting or reporting, such as rate, 5-year aggregate, age adjusted. We have a great glossary of data terms as a resource that we'll share with you after the webinar. For numbers, quantitative and story qualitative data, you want to know the exact survey language or focus group questions that were used for the data. This is a question that comes up over and over again with people wanting to know the exact language of the question that's being asked, and whether or not multiple questions were used in order to calculate or aggregate the data. So especially for BMI, someone might say, well, how do they know? Not everyone knows what their BMI is. It's actually created by height and weight questions in the survey. So just knowing about those little things will help you be able to talk about the data a little bit better. For methods, you want to be prepared to discuss the basic methodology. Emily alluded to this a little bit earlier, of your numbers and story data and the analysis, and know where to direct people if they have further questions. So really documenting the methodology and then being able to share it back out or direct people to documents about your methodology is going to be really important. For data limitations, you want to be prepared to discuss the limitations of the data, such as the methodology, if there are a few small numbers, if it's self-report, just the different types of limitations you might encounter in your data. Just be prepared to discuss them if you're reporting in a presentation or a document. Some best practices for numbers or quantitative data. You want to be careful when you're reporting small numbers and use proper disclaimers. For local or regional survey data, we actually suppress the data that has a numerator less than 10 and a denominator less than 50. So if we have 50 total people respond and there's less than 10 of them that answer yes, we will actually suppress that number since it's less than 10. We do this at the regional level because we don't want the numbers to get too small, because they stop being representative, even though our regional data is weighted. This is aligned, I believe, with the BRFIS recommendations. I think Annika can probably correct me if I'm wrong there. For the secondary workbook data on vital events, we got this information from the Center for State Health Statistics. You can provide counts for vital events. So for births and deaths, that is a matter of public record. But remember that small numbers are likely to be unstable. So when you are reporting them, you will want to give that disclaimer. For healthcare and protected data, an example would be cancer incidence or hospital discharge data. The center recommends that you not report a number less than 5 events. So that would be 1 to 4 events. 5 is not considered, it's not less than or equal to, it's less than 5 events. And I believe, Marion or Annika, if you're on the phone, you can report 0. If you're breaking this data down by categories or demographics, the center recommends that you not include any information that has less than 5. So if you have less than 5 people in a race category, you wouldn't want to report that. And you need to have at least 2 categories that have greater than 5 to be able to report a breakdown of the information. For crude rate and age-adjusted rate, the center recommends not reporting out rates less than 10 and crude rates less than 10 and age-adjusted rates less than 20. You'll often come across numbers bolded or in italics and see warnings such as rates appearing in bold type are based on fewer than 10 cases per year or 20 cases in a 5-year aggregate. Such numbers or rates are unstable and should be interpreted with caution. That's a note you'll see often in the secondary data workbook. You'll also want to be careful when comparing it to the regional mean. If there are unstable rates included in the aggregated data in order to create the regional mean might not be as meaningful. So just to keep that in mind. And realize I just threw out a lot of terminology in this section. Once again, we've got a glossary in the resources if any of these words look unfamiliar. So be careful when reporting small numbers. For county-specific data, you really want to use caution when reporting numbers, especially reporting on sensitive subjects, substance abuse, mental health, sexually transmitted infections, all that data coming out of NC Detect. The State Center would recommend that if it's less than 5, you'd want to just say less than 5. You wouldn't want to include the actual number. And when possible, report percentages or use reporting language such as there were less than 5 hospitalizations due to opioid overdose from January to July. So just an example of the language you could use. Emily?
Great, thanks, Jo. So in general, qualitative data or your story data will often be reported using a combination of key themes that you've identified across qualitative responses, as well as specific examples or quotes that you would include to illustrate those themes. So for both of those kind of methods of reporting qualitative data, some general best practices might include obviously not including personal identifiers or information that could be attributed to a specific individual. So obviously this would include the 18 identifiers Jo described earlier. And then also within small sample populations or small communities, identifiers may extend beyond those 18 kind of standard ones to possibly include occupation, location of residence, health history, and others. So when you're considering whether or not to report qualitative data that refers to a particular individual or case, just think carefully. If a community member were to read this information, could they tell who the data refers to or who said the quote? And then in addition, on the previous slides, Jo discussed how a quantitative data best practice is to suppress data with small total counts, or particularly small counts that refer to sensitive subjects. So I'd love to hear from other data experts on the webinar about this, but my recommendation would be if you're going to suppress quantitative data about a particular subject or due to small counts, that you also would not want to include the qualitative data, because that, especially with small counts, that could be considered identifying information. If you do decide to include direct quotes for other data, other qualitative data, just be sure to remove all references to specific individuals. And this would include both the person who provided the quote and any other person or people they might refer to within the quote itself. And then, of course, always identify direct quotes by including them within quotation marks. Jo, I'm trying to advance the slide, sorry, but it's not working.
Did it go?
Nope.
Oh,
not for
right.
me. Oh, there you go. Just shot past it.
My bad. Data reporting for scorecard. There we go. Indicators and performance measures. You want to never ever include individual data in the scorecard. All data in the scorecard should be aggregate data. And under no circumstances should any PHI end up in the scorecard. You want to use caution when reporting numbers, especially when reporting on those sensitive subjects that we keep mentioning. Use percentages or rates when possible, or you could even put 5 and add a little call out box that says this number is not actually 5, it's less than 5, unable to report due to the small number. Just be careful with what you're reporting in scorecard, especially if it's a public work group document, because once you create those embed links and you share them out, that is a link that can be shared with other people. It's a live web link. So just be careful and consider your options when you're reporting that information. For story behind the curve, you're always going to want to get permission if you're going to include quotes, even if they're anonymous in your scorecard. It's always a good idea, even if you're going to post a quote and it's anonymous, that you just, even if it's just calling up the person who gave you the quote, to ask them if it's okay if you put it in their scorecard so they don't see it in the meeting when you present your scorecard and get freaked out. You also do not want to include individual data or any identifying references to individuals in your scorecard. Unless you have their permission to do so, you want to just make sure that you keep it confidential and keep that out of your scorecard.
So this webinar today has provided a broad overview of the general ethical principles you'll need to consider as you collect and store and share your data. There are lots of additional resources available out there that provide more specific guidance and examples, for example, for consent forms, for specific data collection tools, interview guides, lots of other aspects of the topics we've covered today. And this slide includes links to just a few of these resources. You'll notice many of the resources on this slide come from IRBs of various academic institutions. And as Joe mentioned at the beginning of the webinar, the type of data you will be collecting will likely be more kind of for community use, for your own internal use, likely not for publication in peer-reviewed journals. However, the same basic ethical principles apply, so hopefully these resources should be helpful guideposts. I won't go through these in detail, but there are links included on the slide, so we'll share the slides after the webinar, and please feel free to click through. And then obviously, if you aren't able to find the tools that you need, we may be able to help. So Joe, if it's okay if I offer for folks to get in touch with us if they have follow-up questions.
Absolutely. Yeah, I think that goes for anything that was mentioned here today. If you have a specific project that you're thinking about, if you need help thinking through it, and who you might need to talk to, what you might need to do for collection, sharing, reporting, if you just reach out to me or Marion, we can put you in touch with someone who can help you out, if not help you ourselves. So definitely reach out if you have any questions.
Great. So with that, we'll open it up for questions, thoughts, any additional input. I know we have a lot of knowledge among those who are listening in on the webinar today. We didn't have any questions chatted in, Joe, so I think maybe we can just open up the line, and if anybody has questions, please feel free to chime in.
I will, and I'm actually going to just FYI stop the recording right now, so if you have a question, don't worry, it's not going to be recorded. And we are going to actually put any questions in an FAQ document.